Excellencies, ladies and gentlemen, thank you so much for being in this session. I imagine that all of you here heard Michael Phelps, and the words, "it's okay not to be okay," just about sums up the way that we have to approach the whole question of anxiety and depression. It represents an enormous challenge, because the figures are indeed enormous. We're better at talking about it now and identifying the problems, but the figures from 2017 reveal that at least 322 million people have depression, 264 million live with an anxiety disorder. The WISH report comes to us all as a challenge, a real challenge, a personal challenge, a community challenge, a government challenge, a countrywide challenge. Because of all that, and because you indeed do come from all over the world as part of the WISH community, we're very keen for your involvement in this session. And indeed, we will be talking about the impact which we want to identify of anxiety and depression as the largest global cause of disability, with a massive economic cost. And what we see time and again when we're discussing things in WISH, like eye care, like viral hepatitis, it's the actual economic cost of not dealing with these things is far greater than the cost of dealing with them. The rates of anxiety and depression are rising in every single community. There is a huge stigma in some cultures and some groups, and it needs a whole society approach. And we know the drugs may be a contributing factor to recovery, but they're certainly not the whole story. So I'm going to introduce our panel now. Dr. Sadria Al-Koffi has pioneered much of Qatar's care of children. She's the national lead for healthy children and adolescent health strategy for Qatar 2018 to 2022. She's got a massive job, but she began the autism spectrum disorder screening in 2012. And developed the Child Health Notebook, which is a great thing, which is what the patient holds their own comprehensive health record. She is a community medicine consultant and is very welcome on the panel today. Victoria Hornby is the Chief Executive Officer of Mental Health Innovations UK, which is a brand new charity founded with a grant from the Royal Foundation of the Duke and Duchess of Cambridge and Prince Harry. And it aims to use digital tech to increase access to mental health support. And that's one of the big things I recall really from the conference 2 years ago, is how much more we are talking about the ability of tech to help us solve so many of our problems. For 6 years prior to her new role, Victoria was Director of Programs at the Royal Foundation, including the Invictus Games and Heads Together. Neil Leibovitz is the Chief Medical Officer of Talkspace, and you heard a great shout out for Talkspace from Michael Phelps. He's also a psychiatrist and attorney, and as we know, obviously, that Talkspace is a tech company whose aim is to expand access to mental health care and build collaboration amongst providers. Way back in his life, he supervised mental health care of inmates in the New York City jail system. And also, beforehand, he was also a Senior Behavioral Health Medical Director at United Healthcare. Shekhar Saxena is a visiting professor at Harvard T.H. Chan School of Public Health. For the past decade, he's been the director of the Department of Mental Health and Substance Abuse for WHO in Geneva. He's an editor of the forthcoming Lancet Commission on Global Mental Health and Sustainable Development. Maria Elena Medina Mora is the head of the Unit of Global Mental Health Research, National Institute of Psychiatry in Mexico. She's also a member of the WHO International Advisory Group for the revision of ICD-10, mental and behavioral disorders, and is chair of Field Studies Coordination Group and has won several excellence awards in fields of drug abuse. First, though, to introduce the report, to speak to the report, and also with that, I must thank all the people in the room that have contributed to this tremendous report. You must read it. The case studies are fantastic. I want to introduce the forum leader, Paul Farmer, who's been the chief executive of the leading mental health charity Mind for 12 years. He's chair of NHS England Mental Health Task Force, bringing together health and care leaders and experts in the field, including people using services themselves to lead programs of work to create a mental health 5-year forward view for the NHS in England. Before we start the conversation, let's hear from Paul.
Thank you very much, Kirsty. Good morning, ladies and gentlemen. I've just worked out I'm not quite as tall as Michael Phelps. I'm definitely not as good a swimmer as Michael Phelps. But what Michael Phelps and I have in common is a shared passion and commitment to address this issue of mental health in our society. It was a joy to hear Lord Darzi earlier yesterday say that there is no health without mental health. The stark truth, however, ladies and gentlemen, is that there's actually been quite a lot of health without mental health. That, I'm very pleased to say, is changing. And this report is an important milestone in addressing and recognizing that there is now no health without mental health. And this report has been pulled together by colleagues, people with their own personal lived experience of mental health problems, and the team from Implemental, to whom I'm truly grateful for their input. Michael Phelps put it extremely well, and in our report you hear this message as well. People are beginning to understand that depression is an issue that affects so many people in our societies. It's an issue which is fundamentally part of who we are as a human being, potentially. If you're wondering what it is, we define it. Depression, it's low mood or sadness that persists for a long time. Or anxiety, feelings of worry and fear, hard to control, and an issue that affects our daily activities. We've already heard about the scale of the issue. It is truly profound in our world. The 322 million people living with depression, 264 million people living with anxiety. And yet, the treatment gap is significant. Our report finds that in many countries, only 1 in 27 people get adequate help. In some high-income countries, that rises to 1 in 5. But that's not really a great achievement, is it? The cost, as we've already heard, is significant. Total economic cost estimates, $1.15 trillion. And our report finds that for a much reduced investment of $184 billion, we can achieve a significant return on investment, and we can also reduce that treatment gap. But it needs commitment, and it needs financial commitment to make it happen. And our report highlights the scale of the issue, because, as you heard from Michael Phelps, the experience of depression and anxiety is not simply one that can be tackled inside the health room of the doctor. We see the high prevalence. We see the consequential high burden on our communities. The low funding, in most places less than 1% of global health budget, of national health budgets being spent on mental health. And consequentially, a very low workforce, around about 1% of the healthcare workforce are mental health workforce. And perhaps the greatest challenge that this issue kind of leads to is that stigma that has for such a long time shrouded this issue. People who are afraid to speak out, afraid to reach out, afraid to even admit to themselves that maybe a mental health problem is developing. And the tragic consequences for far too many people is that people then choose to take their own lives. Roughly 800,000 suicides globally every year. Fortunately, our report finds that this is not a hopeless situation. In fact, there is significant hope. And as the stigma starts to recede as more people, both people in the public eye, but also people in social media or in their own houses, in their own communities, with the people they trust, as more and more people talk openly about their own experiences, we think that we can see the foundations for an effective approach to tackling this issue of anxiety and depression. And our report, broadly speaking, highlights 3 key areas of action. The first area is to think about prevention and promotion. And in our report, we identify 3 routes that you can pursue in order to be able to address that. Thinking not simply about those people who have anxiety and depression now, but thinking about all of us in terms of population preventions and population interventions. So those 3 routes are to think about how we address the life course. We'll hear later about the importance of talking to young people, children, about how they feel about themselves. But also right the way through to the growing issue of mental health issues amongst older people. Secondly, we have really excellent evidence that national campaigns to tackle stigma and discrimination have an impact on public attitudes and behaviour. Campaigns like the Time to Change campaign in the UK or the Like Minds, Like Mine campaign in New Zealand all show us that we can shift public attitudes. And thirdly, thinking about prevention and promotion in the workplace. And one of our polls highlighted in the report indicate pretty much that wherever you are in the world, people are fairly reluctant to talk openly about their mental health in their workplaces. Secondly, we identified a number of areas where an approach, a healthcare approach to adopting this issue can really work and make a difference. And the good news is that these are not high-cost interventions. The stepped care approach, which we saw, for example, in India and Chile, which recognizes that you can take an approach that recognizes that people are not necessarily always needing the intervention of a psychiatrist or a psychologist. Secondly, a collaborative care approach, because in many countries, the approach that recognizes that our physical health and our mental health should be seen hand in hand is a possible ambition. And bringing together the skill sets of those people who work in physical health care to give them additional mental health skills can really make a difference. And finally, the approach of task sharing. And at this event, please do go and sit on the friendship bench. The friendship bench features in our report. We've brought it all the way from Zimbabwe. And in Zimbabwe, it's a tool that enables people where local grandmothers are trained by clinicians to essentially deliver therapeutic interventions. And thanks to our friends at United for Global Mental Health for bringing that to this event. And then the third approach is the potential and the power of digital intervention. And our report, I think, kind of shines a light on the approaches that can be played when we're thinking about digital technologies. And this isn't a one-size-fits-all. This is about thinking about increasing access to services, supporting the extension of that workforce capacity, which is significant, but often they're in the wrong places. Using information and data to better understand what's going on for people. Improving screening and prevention. Empowering people to be able to take control of their mental health needs through a digital route. And connecting people with lived experience. And we know the power of technology to bring people together. My final point is to encourage those of you who have influence or indeed control over your national health plans to download and use our National Anxiety and Depression Plan checklist. We think this is a simple approach for any country to take to look at how to start to put together a plan that can make a fundamental difference to the lives of many people inside your communities. Thank you very much indeed.
Thank you, Paul. So, Ria, if I can begin with you. I mean, the Qatar approach is the whole child approach, and that's really been designed by you and your team. And I think 2 years ago, we talked about obesity as one of them, and of course, you've done a lot of work on autism. But For children and teenagers dealing with so much as they grow up, how do you identify vulnerability to anxiety and depression, and how do you get over all the different conversations that you might have to have with parents and so forth?
Thank you for having me today here. Initially, I want to thank you, Paul, for the nice report. Actually, I read it page by page. I have it my
I'm going to test you on it.
So as you mentioned, that 500 million of the global population, they are suffering from anxiety and depression. WHO says 10 to 20% of children and adolescents, they have mental health disorders, which they appear at the mid-adolescent. And in Qatar, we have some data, according to our camps, facilities, that 30 to 40% of children and adolescents who come to seek medical attention on the mental health, they have anxiety and or depression. Either it is secondary diagnosis or as a primary diagnosis. So this one gives us a good rationale to start focus on the anxiety and depression among children and adolescents. Through working on the strategy, concentrating on the integrated model of care, which is accessible, stigma-free, and it is culturally suitable. To do that, we need a framework of action. Actually, I like the one which is published in this report, which really makes sense and similar to the way that you are thinking of.
So you might adopt this?
Yeah, I think it will. Yeah, it makes sense and logically will be adopted, because for any healthcare plans, you need to do situation analysis. And I really like your checklist that you have published. You should know what are there and what are the opportunities, strengths, and what are the weaknesses and challenges that you should work on. You should set your priorities, because we are passionate to do so many things, so many initiations, but you should go for the first 1 or 3 priorities that you can depend on and gives you proper foundation for your programs. And we should have program implementation, which is depending on integrated model of care, linking the health with the community. So we will become as one community, as you announced yesterday. We should have increasing awareness of the mental health and anxiety and depression among not just healthcare providers, among school environment, teachers, parents, adolescents themselves, and the whole community. How to handle the mental health disorder and how to help each other. We should have bridged the political gap. So I should give more access to the adolescent to speak up, seek help, and express themselves. And they should not be blamed for seeking help for mental disorder. But at the same time, we should balance that one with parental supervision. We should reduce the stigma, because it's very important, and it really limits the access of the adolescent and even the adult people to seek the service.
I wonder how you do it in terms of what settings the children and young people come forward. Because do they know, apart from anything else, their own problems, or they're feeling something different? And I wonder, do they present to teachers, or how are you, as it were, getting hold of them?
Yeah, so that was my next point that I'm going to mention.
Sorry, the flies.
We can use digital technology and innovation. And when I say innovation, it doesn't mean I do new things. I should do new things which increase the quality and efficiency and adds great value to the service. So we can use, for example, helplines. We can use open accesses for the adolescent. At the same time, the teachers and caregivers and the parents should be aware how to receive and how to handle those seeking up messages. This morning, Michael Phillips, he mentioned 2 very important points. One was that he started his journey for the cure by asking for help.
Yeah.
So that was the first step. We take him to the complete treatment and building his resilience for the future obstacles. And one other thing, that he started to use the online help, anonymous help. He got connected to the therapist, he got connected to other people who have the same experience on the same field without knowing each other. Yeah. So in that case, I will own the problem itself rather than going to the confidentiality of the people. So the whole city, the mental health concept, we can embed it in the bigger context, such as healthy cities. Because healthy cities is physical, mental, and social well-being. Those are 3 dimensions of health. Even recently, there is evidence that the emotional disturbances that adolescent, they show during adolescent is because they have immature prefrontal cortex. So if there is a strong relation between physical health and mental health, and you are always talking to providers, forget about mental health, forget about the screening, but once you prescribe medication, please check social and mental aspect, because they are interacting together to give you this complaint of the patient. In Qatar, actually, we started since 2 years now, psychosocial screening for the adolescent through using health assessment. We are doing health assessment plus the physical assessment of the adolescent. Health has 5 components, which is looking at home, education, depression, adherence, diet, and risky behaviors. So it links the mood disturbance to the other aspects, because depression and anxiety, they can present in school as a school failure, drug addiction, alcoholism, sleep disturbance, eating disorder, not doing physical activity. Even I heard from the practitioners, from their experience who are doing health assessment, they told us, you know, the key component that they start with, they ask adolescents about their mood. How do you feel today?
I want to talk to you more about that in a while, but I want to bring on to Victoria, because, of course, you're starting a new digital way of helping people with anxiety and depression. What did you start from? What was the starting point? Because we've got Talkspace. What was the starting point for your new digital venture?
So I think, and crucially, when we were running the Heads Together campaign in the UK, and we knew that, as we said to people, you know, you should talk about how you feel. The first step is to talk about how you feel. And so we knew that people would need more places to talk. And some people, you know, feel very happy, very lucky. They can talk to family, to friends. A lot of people don't feel comfortable talking to family and friends. And I think, you know, we need to have as many places where people can feel comfortable talking as possible. There's a recent report in the UK showing that 65% of 18 to 24-year-olds would prefer to seek help online. They would actively prefer online support to family, friends, therapists, at least at the sort of beginning of their journey. And we know that that's where people start looking. They start looking online. And so we really need to meet people where they are. I think it's crucial with mental health that people feel comfortable about where they get their support from. I also think for us, we have to be, if you look at the figures that are in the report and that Paul was so clearly articulating, we don't have a mental health workforce big enough to manage the problem that we have. And so we must start leveraging all of the technologies that we have available to us, in part to reach the people that are in need of help now, but specifically, I think, to reach the people, and particularly young people, who are in the early stages of distress.
But when you use tech to kick off the conversation, at some point that conversation presumably is not a tech conversation. That tech, and what Michael was saying was he accesses therapists through Skype or through FaceTime or through just WhatsApp messaging. There has to be, as it were, a competent human being to talk this through at the end. And I wonder, when you look back at the Zimbabwe experience of using people in the community, grandparents and so forth, maybe not talking to their own grandchildren, but just talking, are we leveraging is there more that we can do with, as it were, lower level training, but just people that can help within the community?
Absolutely. And we have just started piloting a 24/7 text-based crisis service in the UK, and that the front line of that service is volunteers. They're all at home, they're trained online, they volunteer online, they're supported by clinical teams online. So we make the most of, you know, highly expert clinical expertise in backing up volunteers to be that first place where people can get support. And actually, one of the fascinating things for us in the early days of running this service is that one theme which comes up so much, and I think Michael was talking about it this morning, a lot of the young, and it is primarily young people that we're talking to at the moment, don't believe they deserve help.
Because they think they think their lives are are good.
And or that the problems they have are their fault.
Yeah.
And therefore they are not deserving of help and support. And often the first barrier to people getting the right kind of help is to feel deserving of support, that they deserve the support that they need. And that doesn't need to be a specialist, a highly trained specialist that delivers that message. That could be you or me or anyone else who says to someone, what you are going through it's not your fault, it's not to be ashamed of, you need to get some help.
But it's so interesting because in the online space, as well as help, there's the most appalling abuse going on in the online space, be it Twitter, whatever else. You've got these twin things pulling at you. You know, I did a program about that whole thing about young women, adolescent girls having terrible times online. At the same time, you're asking them to trust online for help. That's a big trust issue, isn't it?
It is a big trust issue, but I believe that we must use digital. It is our best chance of meeting the scale of the need that we have, and so we have to find ways of making the online world safe. Just safe anyway, but certainly safe for finding support. And I think, again, not the mental health profession, the public has a big role to play in that. And the more people we can train to be comfortable in that early conversation, the better we will be.
Neil, just coming to you, a psychiatrist and a lawyer dealing with a whole idea of whole population therapy. Tell me, I know I want to ask you about your own thing, but just going back to what Victoria said here, Talkspace, about the idea of making it a safe space. How much work did you do on that before you even launched?
So that's a great question. We really work very hard to create a safe space. We want people to be comfortable. One of the things that's really been interesting for us has been our work on trauma. What you see is a huge dropout rate for most people with post-traumatic stress, especially men. So we're actually in the final stages of a study with Duke looking at PTSD, and what we've actually found is people come online and some of that confidentiality and anonymity that they can have creates a safe space for them. And they open up, and in some ways the outcomes are better with certain populations than you would see really with face-to-face bricks and mortar treatment.
So when you came to design Talkspace, and so what were the imperatives that you're looking at? And as much as you have online, I don't necessarily want to talk about the royals, but having Michael Phelps, having Prince Harry, how important is it to have people that we all recognize and know talk out?
So very important to have people who can really normalize mental illness in society and make people comfortable. When you see someone like Michael Phelps, he really is not the image of what we think. Someone at the top of their game, someone who's male, for example. With men, the stigma is still greater. It's very large with the male population. So having a male role model for people with mental illness is really important. The other thing that's interesting that you touched on is when we were thinking about how to build this, most of the time we talk about user experience, patient experience, very important. However, if you really want to have any lasting value today, it has to be research-based, it has to be data-driven, and it has to really be real. You have to open it up, bring it out into the public, learn from it, and work with some of our partners in not-for-profit and government. Business cycles are moving very quickly. One of the things I'd like to see change is having smaller grants that can quickly be given to companies with promising technology, leading to larger grants. One of the things we struggled with in our early stages was how do we fund research?
Well, I was going to say, were you an attractive proposition, really? For research funding?
You're only attractive when you're successful.
Yeah. And what about but spinning out those whole ideas of evidence-based therapies? Because you're saying it's all about the data. So how much of Talkspace's work is, as it were, customer-facing, and how much is the research that drives what you actually put on that app and how you talk to people?
So we have a wonderful slide in a non-slide presentation of an iceberg. And I wish I could show you. But with an iceberg, what you see is the tip sticking out of the water, and down below is really the core, which is many times as big as the iceberg. And with any science, with any application, with anything that's based on technology, it has to have that anchor, which is the evidence, which is the knowledge on how it's built. It has to be well designed, well thought out, has to have that data-driven notion. And the other thing that I think it also has to have is we have to figure out how to adapt technology to help providers and not have providers serve technology. We spend a lot of time trying to make therapists better at therapy, give them the tools to be better at therapy, not make them work for the technology.
So, before I come on, because this is going to be your area that I want to talk about, but I want to ask you one final question on this. When you have the online conversations, and you guarantee anonymity and so forth, do you capture those conversations as evidence, and that will that in itself lead to prevention and strategies of dealing with the possibility of the signs of mental health? I mean, can you capture these conversations in a way that can be data rich?
So on both a micro and macro level, you're absolutely correct. On a micro level, we capture the conversation. So as a patient, for the first time, you can go back and look at what your therapist said to you. Maybe they showed you a breathing technique. Maybe they sent you a video, and you're feeling down now. You can go back and look at where you were. You can see your progress. On an aggregate notion, like many companies, we collect data, aggregate it, we de-identify it, we do not sell it. But what we do is we try to learn about therapy, what works, what doesn't work. Unlike diabetes and hypertension, we really don't know as much about mental illness as we think we do. And one of the things that we'd like to do as a company that really contribute to mental health is use that data to provide insight and real-time insight to therapists. How can they be better?
Well, Shekhar Saxena, you're all about prevention, both as a psychiatrist and also having worked at the World Health Organization and Harvard School of Public Health. What are the best prevention strategies?
Thank you, Kirsty. The big message from this WISH report on anxiety and depression is that prevention is possible. And this demolishes the general perception amongst the population, also amongst the policymakers, that mental disorders have some kind of inevitability. Nothing can be done, which is absolutely wrong. Of course, there is a lot of progress on treatment, but there is a lot of new knowledge on prevention of mental disorders. Not all mental disorders can be prevented, but a large majority of them can be. And anxiety and depression, also substance dependence, are such disorders. And this prevention is possible at individual level, but also at population level. And both may have different strategies, but both are effective. Let me give you an example. In fact, we can divide, as the report does, divide the whole thing into life course. The first stage of the life is children and adolescents. And much can be done at that age to prevent future anxiety and depression. And these are simple techniques, these are simple policies, many of them outside the area of mental health. And that's where the whole society, whole of the government approach becomes absolutely critical. Ensuring adequate nutrition to infants and children is absolutely necessary. And we do know that children who grow in a nutritionally deficient environment have a higher proportion of anxiety and depression, also of some other illnesses. The environment has to be safe. Children have to be protected from physical and sexual abuse, which, as you mentioned earlier, can also be online nowadays. And that kind of safety, the society has to build in so that the future problems are avoided. There is also need for adequate psychosocial stimulation. Children who grow in a socially deprived environment have a much larger mental health issues than other people. And finally, prevention of early use of alcohol and drugs can again be very useful. So these are some of the techniques for children that are extremely useful for population level prevention. Obviously, there are also individually directed techniques which can be useful.
But also at the other end of the scale, you've done work on mental health issues among the aging population and some techniques that can be developed to halt that, to lessen that. Are we paying enough attention to that?
Again, very important because we live in aging societies and more of us are surviving to an older age group. And we do know that depression is much more common in late middle ages and also in old ages, and also other conditions like dementia take over, which have a substantial overlap with depression.
Yeah.
And again, much can be done about that. The first issue actually is decreasing physical disability and disorders, because those go very clearly with depression.
Yeah.
If a person is disabled, also because of sensory deprivations, eyesight, hearing, if those are compromised, then the chances of depression are much higher. But also, healthy life and lifestyles are very important. And again, use of alcohol and drugs can lead to depression. Good nutrition is again important. Physical exercise has been proven to be of preventive value for depression as well as for dementia. And cognitive stimulation techniques can actually be used so that if you, just like, you keep yourself physically fit, and some of us wear this kind of bands, there need to be something much more on tracking one's emotions, which Michael Phelps talked about this morning. We need to track how we are in our anxiety, in our depression, how we are in our mental abilities, and that can all be very much preventive. But last thing I also want to mention is that just like the physical abuse amongst the children, physical abuse and neglect amongst old age people is also a very critical issue. Yeah. And we do know that isolation and neglect is very clearly associated with depression.
I was watching a program. There's been a number of different things around in different countries about care areas for elderly people being put together with nurseries for children. And that interaction is automatically stimulating. Elderly people who perhaps didn't engage with the world suddenly have a 3-year-old tugging at them. And again, that 3-year-old understands how to operate with older people as well.
This can actually be beneficial on both sides.
Yeah.
For children as well as for older adults. But let me just deal with one more issue, which can, of course, be also very preventive, which is in the middle, in the regular adult ages, which is mental health in the workplace, which has been also dealt with in the report. And also, there is a Lancet report, Lancet Commission on Global Mental Health and Sustainable Development, launched just last month, which is written by 28 people. And I was fortunate to be associated with that. That also has focused attention on prevention for the first time, because earlier reports have all talked about treatment, but prevention is becoming very, very important. And mental health in workplace can actually be a very serious and substantial improvement on people's mental health as well as preventing mental disorders.
If every workplace would agree to have that kind of program. Maria Elena, although you've been working in drug and alcohol addiction, just carrying on from that position, you're a prime position to see how it links into depression and anxiety.
With drug abuse problems are, of course, part of mental disorders. And many times they come together. Around half of the population that have substance use problems also have a mental disorder. And if you have severe cases, it will come over 80%. So treating them both together becomes very important instead of treating one in one premise and then substance abuse in another, because they interact in many ways, and treatment also needs to be special when they come together. So what we have done is, as we don't have enough resources to deal with the big problems, as in many other parts of the world, because the treatment gap is very big, and when you come to certain populations, it's even bigger. For instance, if you talk about females that are depressed and also are having drug problems, and the burden of this type of population is very big because there is a lot of stigma against females using substances. So we have developed interventions, online interventions for them, to deal with both problems. And part of what we have found through research is that young females, when they are in the child rearing ages, do not come to treatment, come less to treatment, when they must be more than in treatment than in any other age. So what we do is try to give them the abilities to learn how to come to treatment, because we never teach people how to seek for help. And when it goes against their cultural...
I was going to say, what is the stigma attached to that, particularly from a mother with a child who said, I'm not worthy to be this mother of a child, so I better not show that I'm vulnerable in another way.
That's absolutely true, and it's very bad for the child, and it's terrible for the female. So these type of interventions, when they feel secure, when they can chat with each other and talk about their own experiences, that's what makes them come back to the intervention, and then you teach them how to seek help. Because
so you're teaching your medical professionals and your caregivers to identify and deal with all of these issues in, as it were, one treatment plan.
Yes, and the other issue that we find is that we can get resources for these interventions through research. Mm-hmm. And when research is over, it's very difficult to find the resources to put them in practice, because implementation research is not funded and continuous research is not, activity is not funded. So what we are trying to do is to get resources for that and to develop help from other sources so we can do that. For instance, one of the main problems with caregivers that have children or husbands or wives with mental health problems or substance abuse problems. When they come to treatment, we treat the family also. And then we have the family to teach other persons that are not coming to treatment, so they can find out how to get help, and they become really caregivers of other family members. And when we have someone that doesn't want to come to the hospital for treatment because of stigma or related issues, they go first with these family members, and then they learn what the disorders are like, what is treatment, and then they're ready to come to treatment. So I think that by using all these resources, you can find ways to improve the treatment gap. Yeah. The research gap is more difficult, so we think we have to learn more on how to really get all these evidence-based interventions that are very good, but they don't get to the people.
They don't get to the people. Sadria, just on the question of dealing with children and adolescents, how much can you, as it were, educate parents to do the help themselves of their children?
Regarding the children and adolescents, we have here, maybe globally, there is a political gap that you cannot handle children and adolescents without parental agreement.
Yes.
So once they come to the clinic and they want to speak up with the physician, first question they ask, do you share it with my parents? And the physician should be honest. He will say, yes, I have to share, maybe not the details, but the diagnosis and the problem. And the treatment plan should be shared with their parents, because even the secondary care are not accepting adolescents without parents. So we should aware the parents that we are not breaching the confidentiality, but we are giving you the appropriate help for your children and adolescents. And it is not confidentiality, because if he has risky behavior, maybe the whole community, they know about it. School, peers, neighbors, but the parents, they don't know. Once we bring it to them, they feel that it is confidential. No, it's not confidential anymore, because the risky behavior, he will do this within his community. Yeah. So we are trying to get that access, that empowerment of the adolescent, that at least they can come and speak up to the care providers or community care workers, and we can give him the help that is not so, we can give them the initial help, but if there's any treatment plan, should be discussed with the parents, because at the parents, they will have responsibilities.
So I wonder, on the basis of Talkspace and also Victoria's new, and would you, if you developed something for children and adolescents to do online, would that that could be private to them as well, or would that breach confidentiality?
Yeah, that is my second point that I wanted to comment, because you mentioned something about the quality assurance of the online treatment.
Yes.
I think it is good way because it will reduce the stigma. Even for the parents, it's not so bad because adolescent is seeking help rather than mentioning the name and name of the family or the identification of the parents. They can seek help. And most of the mental health intervention is just talking, psychosocial support, and assuring the patient they can seek help. But this conversation we should consider quality assurance methods. The conversation should be recorded, should be reviewed by professionals from now and then. And at some point, I think I can control the quality of that online more than the live one. Because I cannot register the interview between the physician and the adolescent. I cannot go to the clinic and take the video, say how the physician is dealing with the adolescent. But the online one, I can record it for the purpose of quality insurance. Right?
What do you, I mean, this is so interesting about the idea that we are going to move towards a lot more online treatment.
Well, I think as the panelists have all said, there's no option. The treatment gap is so vast across the area that we don't have the time, and most countries don't have the resources to be able to adopt a kind of 20th century approach to this issue. It has to be a 21st century approach, and so some of the challenges that presents are around quality issues. There's a question about safety, privacy, and I think there's also something about how do you make sure that that people are able to access at the right kind of level. So one of the risks about this whole issue is that potentially we pathologize on happiness, and we turn unhappiness into a mental illness. We don't want to do that. These are normal human emotions that we need to help and support people with. So a kind of citizen-to-citizen approach to help and support people with normal human emotions is a really powerful tool, we think. But the next stage is then how do you help people then to go up to those next levels in a safe space?
How do you do that, Victoria?
Well, I think that working? Yeah. I think there are two things which are really critical in there. One is how do we make sure that technology is safe? And I think that is that's a critical question, and one that we've spent quite a long time thinking about. There are absolutely, and I'm sure Talkspace does the same, there are very simple ways of making sure that every single conversation that takes place online is recorded, watched, monitored for safety's purpose. But I think the sort of byproduct of that safety is then data.
Yeah.
So,
and it's physical data. I mean, you can see people as well as having the WhatsApp and everything else.
Yeah, and I think, I mean, you're absolutely right. I think in saying that it gives people an opportunity to go back and look over, conversations that they've had. But it also enables us. I mean, in the UK now we have what I think is verging on an epidemic of self-harm, of young people self-harming, and we don't know why. Yeah. We don't really know enough about it. We've taken so far in 6 months over 6,000 conversations about self-harm. We should be able to use that data to help academics and clinicians to understand what is driving self-harm. And that we can do that much more quickly the more we start to engage with people safely online.
I want to open out to the audience. I just want to ask one question of Neil Leibovitz on this. Because if we have this problem that we've got 322 million people suffering from depression, we cannot deal with them all online because we don't have the expertise. So at what point do you limit? I mean, how many people can you deal with at Talkspace?
So it depends. But
you have to train the people.
But what we can do is expand the box. So one of the things that technology can do is we can treat people in rural areas who don't have ability. We can expand that workforce. We can scale that.
1% of the world healthcare workforce is working in mental health. I think that's an incredibly scary statistic.
We can't solve that. But what we can do is expand access. And I think some of the things we've been talking about are using other professionals, but also using our current professional pool and making them more efficient and more effective. What do some of the therapists that are involved with Talkspace who provide treatment do? Some of them are moms on maternity leave who have a couple hours a day, who wouldn't be using those hours otherwise. Some of them, someone like myself, I used to have a private practice at night and then I had twins and that was the end of that. But what can I do when my kids go to sleep? I can work for an hour now, whether it's on a video or on some sort of messaging or through Talkspace. So I think one of the things we can do is expand capacity. We're not going to solve the 1% problem, but we can definitely contribute to it.
But presumably when, even if it's, not even if it's, when it is online and you have somebody seeking help, they want to probably, am I right in saying, speak to the same person each time they get in touch or not? I mean, I'm unclear about this, but do you want to develop a relationship with your therapist? Clearly that is what Michael has. Or that's not going to be possible, is it?
So for us, it is the same person online following pretty much every day, communicating back and forth with their client. And where it becomes scalable, and there is some scalability, is they can manage more clients on a platform like that because of the frequency of touches. It's high frequency, but it's not spending 45-minute increments.
Is that going to be done entirely? It's not presumably a possibility to do that entirely on a voluntary basis. You have to, you remunerate.
Yes.
You do remunerate.
Yes.
Yeah, that's interesting, Victoria.
So we pay our clinical teams, and exactly as Neil was saying, we have been able to bring people back into the workforce who can now work from home in kind of 4 to 4 hour stints, really. So we've been able to bring a lot of people back into the workforce. I think the other thing that is absolutely crucial is that when people are really struggling with their mental health, quite often they're doing that in the middle of the night. And we are able to respond to people in the middle of the night. Now we can do that, because people stay up late, but we can also do it globally. Yeah. And that's a really interesting perspective.
Kirsty, I just want to come back to your 1% point. That is the figure for health professionals who do mental health. But this can be improved because there are health professionals who are not trained. Yeah. So there are doctors, there are nurses, and in many countries there are healthcare providers, even volunteers, who should be trained. Yeah. And there is enough material now and enough evidence that with training and support and supervision, every doctor, every nurse should be able to deal with things like anxiety and depression. And we need to do that urgently.
Let's get the hands up now. Microphone holders, can you put your hands up so I can see where you're all? 4 or 5, okay. Right, we've got hands up. Gentlemen, 2 people right in the center here. Can we get microphones here? And the women in 4 lines up first. Could you bring your microphone? Could you keep your hand up? There we are. And take the microphone there. Okay, first of all, can we have, who's got a microphone up at the moment? Can we have microphone 5, please? Who's with microphone 5? Could you hand the microphone in, please? Okay, and that is microphone 3. Could you stand up? That's microphone 3 first. Thank you. Could you give us your name, please?
Hi, my name is Prativi Hastania. I'm a nursing student with University of Calgary in Qatar. My question is, how can we encourage young people to seek mental care when they think that their mental health problems is not as bad as what they see in the media or what the symptoms online are saying?
Let's just pick out Hidia. You do that one, please. Yep, you take that one.
So, as we mentioned before, we need public awareness, community-based campaigns. We need to open the lines for the adolescent and always mention that the mental health is part of the general health, and how the mental health feeds in your physical health, school performance, being more accepted by your peers, building more friendship relationships. So it comes all from the background, and in that way, indirectly, you should work on the families and the parents. Because at the end, the home environment, that is the initial environment that the children and adolescents, they are linked with, and they will they will bring the concept to the adolescent that don't feel shy. You are not be blamed if you seek any help for your mental health.
Microphone 2 now, please. Please stand up. Thank you.
Good morning, everyone. Thank you to the speaker and the panel team. My name is Mariam Lutawa. I'm Executive Director of Nursing in one of our hospitals, the oldest hospitals in Qatar. It's Ramila Hospital. Under my service, I'm having a huge workforce. My question is, because really I'm considering the mental well-being as physical well-being for the staff. How we ensure that I appreciate that we have now the anxiety and depression checklists, but if we'll be able to identify this and we'll be able to use this checklist, how frequently we can use it? For example, if you do it now and I'm mentally fit, how frequently I have to repeat it for my team? And to be honest with you, during our recruitment, I'm not talking about the medical team or nursing or allied health, the support service as well, because the challenge is if we have people with mental health issues with our working force, it's reflecting our patient experience and our operational work day by day. So we have challenges. If we identify those numbers right now within our workforce, how will be able to cope with the numbers that they were identified?
Paul.
Thank you.
So I think you're raising a really important question about the workforce generally. So mental health in the workplace is such an important tool for improving the quality of the workforce themselves, but also it's the place to deliver those interventions. Most of us won't have received messages about our mental health in school, so doing it in the workplace is really key. So, and it's particularly true when you're thinking about the health workforce itself, who is in fact often the least well prepared to look after their own mental health.
Exactly, and in fact, the NHS in England's sickness rate through mental health issues is huge.
So it costs in England, you're absolutely right, Kirsty, £2,000 per member of staff of a 1.5 million workforce. And in the Thriving at Work review, which we produced for the UK government, which actually can be replicated anywhere around the world, an investment in the mental health of the health workforce, we think could deliver a significant return on investment. So start with the very easy things, a mental health at work plan for your workforce, and secondly, raising awareness and encouraging conversations amongst your workforce.
Microphone 5, and I'm going to take 2 together, microphone 5, because the woman in pink behind is also going to be speaking. So let's take 2 points together, because we've got a lot of hands up. Yes.
Linda Gusk, I'm a retired psychiatrist. I am a member of the mental health workforce who got treated for depression and carried on being able to work. So it's perfectly possible. I do think, though, one thing that people ask me who've experienced mental health problems is, if there is truly no health without mental health, why do we always have to make an economic case for the treatment of mental health? And I think that's something that, I have to answer, and I'd really be interested in how other people answer that question.
Yes, take that away.
Thank you very much for asking that question. I think it's an extremely important question. Mental health has been neglected and ignored and underfunded for such a long time that people are discovering all kinds of arguments. I worked for 20 years in the World Health Organization, and we believe that health is valuable in its own right. It should be available to everybody just because it is health and it's a value. But we do sometimes walk into the offices of the World Bank, and then we use the dollars argument. But I must agree with you that the economic return on investment is a secondary argument. It's the avoiding of the disability. It's the moral argument. People who are suffering need to be treated, and their health needs to be improved is the primary argument, and that's what we should be using.
Yes, the woman in pink, who's also got the microphone at number 5. Thank you.
Thank you. Hello, my name's Sarah Klein from United for Global Mental Health. Thank you for thanking us for bringing the Friendship Bench, for example, from Zimbabwe, and that was a low-cost, deliberately low-cost, low-tech intervention that's replicable. I've been working with Shekhar and others on financing, so this came at the right moment. I don't think it's been talked about very much at WISH, but it would be good to get a sense from the panel about how to make the case for more funding for mental health by governments as well as other stakeholders. I know it would be great to hear, for example, why Qatar has invested so much and how you could help inspire others. Thank you.
Maria Elena, just expand on what you were saying about getting more funding, but actually using the funding you have in a smarter way to put different issues together in one patient's care.
Yes, I think that there are many ways that you can use little funds to do a lot of work. For instance, we work in communities that have a lot of violence, that are conflicted because of the drug cartels in Mexico. And one big state, we have 2 psychiatrists. That's the place where most of the homicides are occurring. And we have people going to the communities to do research, to develop programs to help the children, and to develop the programs to help the parents. What then the program finishes, because we don't have funds, then we use telemedicine to continue doing the intervention. So we have the people that were working in the community now back in the institute continue working through telemedicine, and that's a very useful way also to train other medical doctors, to train nurses, to train any source in the community that is willing to help others. Of course, we have to evaluate what level of interventions each one can make, but then we are reducing abuse rates and also depression among families.
Victoria, you want to come in on that? Yeah.
I just want to say something about the financing of mental health, which I think is particularly a challenge, and it comes back to the earlier point as well, which is that in healthcare generally, poor healthcare, the costs of poor healthcare accrue to the health sector. So obesity, for example, contributing to diabetes and therefore costing the health service a huge amount of money. The costs of poor mental health actually accrue across a much wider area. So, young people not finishing their education or not feeling able to build relationships, to get a job, to have the confidence to be in the workplace, and so on and so forth. They go on. So I think one of the really big pieces of work we all need to do is to understand the costs of mental health much more broadly, so that we can make exactly the same case for mental health as been made very successfully for things like obesity and other kinds of healthcare. But we're going to have to be clever in the way we do it.
Microphone at number 2, and then send the microphone to the woman with the white abaya behind you after you finish, please. Microphone 2.
Hi, I'm Justin from the University of Calgary in Canada. Very good panel this morning. I just wanted to talk a little bit about tech and kids. You hear a lot of research coming out about the isolation that tech can have with Facebook and Instagram and kids spending the time in the phone. Back when I was a frontline practitioner in the emergency department in Canada, the common theme that came in around anxiety and depression with the young people was this tremendous and profound sense of isolation. So I'm really curious to know from the researchers up on the panel doing this innovative work in tech, which I really do feel can build community, what you've talked about or what your research has shown about how to circumvent some of that, the isolation of, the paradox in using technology, the very thing that's creating the isolation to build the community.
Sadria.
So I always say that technology is useful as it is harmful, but it depends on the way that you use it for the children and adolescents. We can use the technology as a tool to give help, to give them information about the mental health and physical health. At the same time, we can reduce the bad attachment to the technology by encouraging physical activity, giving more emotional empowerment to the children and adolescents. So we cannot say we don't to put the technology aside, because it is useful and we are using that one, but make it useful for the children and adolescents. Now we have a mobile app and TV app that you can do physical exercise with that. And you can have brainstorming regarding your anxiety, your bullying. for example, cyberbullying is one of the common problems during in the schools and other societies that the adolescents they are existing. But at the same time, we can use the technology and teach them how to resist that bullying and how to get resilience to the bullying and abusing by others.
Yes, I'd like to take microphone 3 and then back to microphone 2, the woman with the white abaya on, please. Thank you. Yes, microphone 3.
Good morning. My name is Nahla. I am from University of Calgary, and I am already a nurse in Hamad Hospital. I just want to ask Dr. Sadria about in HMC and Ministry of Health, how they diagnose and treat adolescent and teenager from the anxiety and depression. Because some parents they hesitate to give their children medication, which is affect sleep and all. And what is the percentage of successful of treatment? Because in the diagnosis there is some ways or different types of diagnose the patient rather than to ask them what is the complaint, how the doctor are diagnose the patients.
Sadria.
And thank you.
In Qatar, anyway, even globally, there is no screening tool for anxiety and depression among adolescents. We will be depending on the chief complaint of the parents, and most of the time, they don't come and don't tell you that my child and adolescent, they have anxiety or depression. They will say they have aggressive behavior, they are not doing well at the school, they may come with alcoholism, with drug addiction, they can come with suicidal thoughts. So it is the efficiency of the care provider who links and knows exactly what cases the root cause is anxiety or depression, and convene the parents that the way to treat that one is getting the diagnosis and that such service you needed. And I'm against labeling the adolescent with anxiety and depression rather than offering the parents useful services that they can use it and improve the efficiency. The successfulness of the diagnosis, it depends on the efficiency of the practitioner to give appropriate plan and compliance of the adolescent and the parents. But main component is psychosocial support for the parents and adolescents and get them to the accurate points of the plan that they are.
Thank you. Could you stand up? Microphone 2, please. And then microphone 1.
Good morning, I'm Sausan Ahmed. I'm a clinical psychologist and researcher at Sidra Medicine in the perinatal mental health services. And I'm actually going to follow up on his question because he kind of started it for me. I'd like to know from those of you who are involved in sort of pushing for more involvement of technology in delivering mental health services, how do you reconcile the fact that the #1 predictor of whether interventions work is the therapeutic alliance and the human connectedness between the practitioner or the clinician and the patient, with all the research that tells us that digital relationships are not real relationships? So how do we reconcile those? And it seems like we're asking for more and more technology to be involved to fill this gap between, this gap that we have in mental health services. But is the solution to push for more technology? I don't know, I'm a researcher, I'm not aware of any research that shows the evidence-based effectiveness of teletherapy. So I'm just wondering how we reconcile that data that shows social isolation is the #1 predictor of suicide, and people who are connected to and have a human connection with others in a community are less likely to be depressed, anxious, and commit suicide.
Neil.
So I'm really glad you asked that question. Thank you. Before I answer it, I wanted to share one thing in response to the prior question, which is, while there is an isolation with social media, there's also groups of children and adolescents who are now finding each other around the globe with diverse interests. That person who didn't identify with anyone in his class may now have a group of 100 people throughout the world that they can identify. So it cuts both ways. It's not just isolating, it can bring people together. But in response to your question, there's a lot of evidence in terms of telehealth and the bond between the therapist and the patient. One of the things we do as part of our platform is we give the WAI, which looks at the bond between the therapist and the patient in treatment. I'm happy to talk a little more later after the panel, but one of the things that we've found is the bond is very strong. it's as strong as in person. And I know that many people, when they first hear that, have a lot of skepticism, and I understand that. I had some of that same skepticism when I first heard about Talkspace, to be quite honest. And over time, it's become very powerful. And I think one of the things, not just for Talkspace, but for any intervention, that frequency that you're getting, instead of having an appointment once a week or every other week, that daily interaction allows you to build that bond very fast and very strong and overcome some of that you lose from sitting face to face.
Okay, I've got a lot of questions up, so I want to take one. Before we come back to the panel, I'll take 8. So 1 and 8, please. Your comment, please. Could you keep it quite brief? Thank you.
Yeah, hi there. My name is Alexander Gibson. I'm a social worker at Sidra Medicine. I'm interested in the use of digital technology to support people with anxiety and depression. This looks as if it could be an expanding industry. How do we ensure service integrity and oversight and regulation of that industry, please?
Oversight, exactly. Now, number 8, please. Your question, please. Can you stand up with your question? Number 8? No question?
I am Francis Omaswa from Uganda. Great conversation. What happens in the case of the many patients who have symptoms everyone else can see except themselves? Is there a place, and what are the indications for, is it forceful evaluation treatment?
Thank you very much. I'm going to get Paul to take that one. But on the question of oversight, which is the really key question about the tech, which relates to your question as well, can I pick up with you, Victoria?
Sure. I mean, I think we're in the early days and we're learning, but I don't think there's any question that that these things need to be very closely regulated. I mean, what I would say, and I think the vast majority of the tech innovations in mental health that I am aware of probably provide there is a greater sense, I think, as you were saying, a much greater sense of being able to understand exactly what the interaction between the individual and the therapist, or the individual and the volunteer, has been, and so there is a potential for a much better set of records and understanding. Now, the longer term question is, as we move more and more towards, which I think is inevitable, more and more towards technology, how do we avoid the problems that we've seen with, for example, the social media companies?
Yeah.
And a lot of that is really going to be about this being a community of people who get behind technology for mental health. All of us, all of us, rather than...
But people are unscrupulous. You can imagine in a big space where we need a massive amount of tech, a company comes along, sets itself up. How do you know whether that company, you're not a professional, how do you know you're not going to be scammed and they're going to be turning up at your door saying, well, I've actually come personally to see you now? I mean, the problem is we don't have any benchmarking for online yet.
No, and I think we should also be clear that people can go and see lots of people who call themselves a therapist, and I mean, that's not brilliantly regulated either. But I think the key thing is that we all do this together. That we have a way of the mental health community endorsing and supporting and monitoring and watching the development of technology very carefully. It's got to be something we all do together, rather than the kind of free-for-all that we've seen sometimes in social media.
And of course, one way of getting around it on an individual area basis is, so for example, Sidra could have its own online one, which would obviously be monitored, each individual. But on the second point, please, Paul.
Yeah, so I mean, I think our report highlights the really important need to invest in that prevention and promotion space, because as we've already heard, people are still often very reluctant to even think that they might be developing a mental health problem in the first instance. That self-stigma comes before the stigma, and so that's the first place for countries to think about, that investment in prevention and promotion in order to be able to inform and educate people to be able to make the right decision. And in a way, what we're now starting to do is to kind of enter into this kind of broader conversation. I think Linda made a really important point about how do we think about, we mustn't just think about this as an economic issue. Yeah. We have to think about this as a social issue. It's a political issue, and it's also a legislative issue, because individual countries will also be thinking about what is the line of intervention that a state might be taking in terms of the intervention choices that it then wants to make around supporting those people whose mental health is so poor that they do require some form of intervention. It's really important to think about this as a joined up cross-governmental issue.
Microphone 4, please.
Hi, I'm Yusra Majdi. I'm a medical student at Qatar University. So I'm interested in knowing how, let's say, populations like migrant workers or middle-class families can access mental health resources like psychiatrists when their economical status doesn't really allow it. So I want to know if there are any programs or plans in the future to tackle this issue.
Sadria.
So we started at the National Health Strategy. We're taking our first steps. As I said, for children and adolescents, HEADS assessment is free of charge. We started in the school as a pilot and at the primary healthcare centers.
All schools for all communities.
It should be at the end, but we start in phases. We have to pilot it first. For the primary healthcare centers, it is free. And for the secondaries also it's free, because if adolescent is referred to the adolescent health clinic, they are doing HEADS assessment also. So we are not charging anybody for mental health services or screening or getting help. One more issue that I would like maybe earlier to mention, that here in Qatar, we don't have maybe a problem with the funding. So if we need, the government is going to fund us to get more resources on mental health.
So that's for migrant workers as well, their families.
Yeah. So, but again, I stress on the proper strategic planning for the mental health, because if we have money, we don't want to waste it, and we want to allocate it in an efficient way. So in my point of view, having efficient healthcare workers is better than having big numbers with lower than normal efficiency. Other countries, they are using community-based workers who are paid by the government, and for the part-time, they are doing some counseling and psychological support. I'm going to start experience this year with the family support program for autism. I am shifting to the community. I have a group of healthcare providers who are doing family support early birth program, which is we adopted from UK. But I'm shifting now to the community, and I will tell you the result in the next wish, inshallah. We will see how the community-based workers will work.
Right. Yeah. Great. Now there's lots of microphones up. I'm going to take microphone 7 up at the top. Could somebody stand up there, please?
Hi, my name is Charlene Zunko. I'm from South Africa. I was also fortunate to be on the advisory board of this powerful report. I think, first of all, mine is more of comment. If we look at how long are we struggling with stigma and discrimination, it's always a huge problem. And what we also heard from Michael Phelps, it's very important to kind of share stories. Recovery stories are so important. And I found from my own personal experiences, when I speak about me living with schizophrenia, people often don't see me as being a human being. And I think sharing recovery stories actually bring in that human element. And then when we speak about the workforce, I just want to highlight and say that peer-to-peer support and peer specialists actually play a very important role and should be acknowledged as a fundamental discipline within the mental health workforce. Thanks.
Thank you very much for your comment. Microphone 4, please.
Hi, I just want first
stand up,
thank you.
sorry, so we can capture you.
Sure. I want to thank you for the very intriguing and interesting discussion. My name is Manaz Musavi, and I'm a psychologist working for Georgetown University here in Qatar. My question is really related to the previous question that was asked here and the response about using the community resources here in Qatar. As you know, we have a very, very diverse, culturally, nationally, socioeconomically, all of that diverse population in this country. And there are some resources already. There are some people who do have a training background in mental health, but that's not regulated, unfortunately. So I'm wondering if there is anything in the pipeline to use the mental health resources that is already available and is not regulated because they're all lumped together as allied professional. So really talking about respect to the professionals who are specifically working on mental health, but there is really no regulation. I'm wondering if there is that to use the existing resources in the country.
Thank you very much. Would you observe that, Paul, from the position of being here?
Well, I think my principal observation would be to recognise that the first resource that we have to support our mental health is our next door neighbour, our fellow human being. And that's the joy of initiatives like the Friendship Bench that we see from Zimbabwe, where you can invest in community-based programs where we know that actually the best impact is when you put people side by side, as Charlene was saying. Peer support is really powerful. And in a sense, what we're doing in the digital space is taking that peer support into a different community. And I think you make an interesting point about how do we then harness the skills of people who have got mental health skills but aren't necessarily feeling fully utilised. And I think there are some mismatches in all countries between those areas, and there's an important need for mental health professionals collectively to work as collaboratively as is possible, bringing their different skills of psychology, psychiatry, social work, and the lived experience that peer support brings.
Very briefly, Sadria.
Yeah, I think once we say that it's a community-based workers, we say that we go for the people who are interested, they have some background about mental health, they have self-experience. So definitely we don't go for the people who they hate mental health, they don't believe in, they don't have any skills, and they don't have communication skills. So you are right, we will be looking at the existing resources who have not been utilized very well, and we will reallocate them according to the cultural and language matches. That is very important.
Ladies and gentlemen, please thank Paul, Sadria, Victoria, Neil, Shekhar, and Maria Elena for their conversation this morning. Thank you.